The bronchoscopist reviews the lung map and plans the order in which the airway segments are to be assessed and treated. Treatment planning is crucial to the thoroughness and ultimately to the success of bronchial thermoplasty, helping to avoid under- or over-treatment of the airways. To help suppress airway secretions, an anticholinergic such as glycopyrrolate is administered at least 30 minutes prior to initiation of the procedure. Properly treating the patient with an effective drying agent such as glycopyrrolate is important in bronchial thermoplasty as it reduces the amount of airway secretions and may improve visibility through the bronchoscope. After the patient's chart is reviewed, the patient is prepped and a peripheral intravenous line is placed. Patient is given supplemental oxygen via oral or nasal cannula and is placed on appropriate monitoring for sedation. The patient is monitored with continuous electrical cardiac or EKG monitoring, continuous pulse oximetry, and continuous intermittent non-invasive blood pressure. A gel-type return electrode is placed on the patient and connected to the Alair RF controller for proper functioning of the Alair system. Once the patient is prepared, the sedation is typically accomplished with IV midazolam and fentanyl. Additionally, judicious application of topical anesthesia such as lidocaine is used during the procedure to control the airway reactivity. The patient's nasal passage, posterior pharynx, vocal cords, and bronchial tree are anesthetized. Bronchial thermoplasty is performed using the Alair system. Connect the foot switch to the Alair RF controller. The single-use disposable Alair catheter is removed from the package and connected to the Alair RF controller. The controller is turned on, a self-test is automatically performed, and a green light signals that the controller is functional. A standard commercially available flexible bronchoscope is placed either via the nasal or oral approach. Liberal topical anesthesia is applied as needed to advance the bronchoscope without difficulty or airway reactivity. As the bronchoscope is passed down the airways, additional local anesthetics are used as necessary. The tip of the bronchoscope is navigated to the region of the lung to be treated. In this example, the left lower lobe will be treated. All targeted airways are inspected before treatment begins. The bronchoscopist plans the order in which the airway segments are to be assessed and treated, assisted by a map of the airways. Here, the treatment plan begins in the anterior, then the lateral, posterior, and finishing in the superior airway segment. Typically, the most distal airway in the targeted lobe is treated first. Once the site is selected, the Alair catheter is introduced through the working channel of the bronchoscope and positioned at the desired location in the airway. At the proper site, the electrode array at the tip of the catheter is expanded under direct visualization to contact the airway wall. The bronchoscopist activates the radiofrequency controller by stepping on the foot switch to deliver RF energy to the tissue under direct visualization. The RF controller delivers low-power, temperature-controlled RF energy to the airway and automatically terminates the energy delivery upon completion of the cycle. A long audible tone by the controller signals the end of RF energy delivery and that the treatment cycle is complete. A single activation of the catheter delivers RF energy over a distance of approximately 5 mm, the length of the exposed electrodes within the electrode array. The bronchoscopist must maintain contact of the electrode array with the airway wall, even while airways remain in motion from tidal breathing. The temperature set point, power limit, and delivery time are configured in the RF controller software and are not user adjustable. The cumulative number of activations is recorded on the Alair controller activation counter throughout the procedure. Following the proposed treatment plan, the electrode array is collapsed and the tip of the catheter is moved proximally 5 mm to repeat the RF activation. 5 mm marker bands at the distal end of the catheter facilitate repositioning of the catheter. This process is repeated and subsequent activations are positioned 5 mm proximally and adjacent to, but not overlapping the previous activation site. Segments that have been treated should be recorded on a procedure form. A systematic approach from distal to proximal, working methodically from airway to airway across the region of the lung being treated, is recommended to ensure that all accessible airways are carefully identified and treated only once. Depending on patient size and anatomy, a range of approximately 40 to 80 activations or energy delivery cycles are performed. This technique is used in all accessible airways distal to the main stem bronchi and greater than 3 mm in diameter. Bronchial thermoplasty for the upper lobes requires additional time for the treatment, as these regions are typically treated within one treatment session covering both upper lobes. The procedure performed is identical to that described above, but requires additional time because it involves navigating the tortuous anatomy of the upper airways, and additionally, it covers more area than either lower lobe. Depending on patient size and anatomy, a range of approximately 60 to 100 activations is performed in the upper lobes. Following the completion of the bronchial thermoplasty procedure, the patient is awakened and begins recovery period. The patient is observed in the recovery room until lung function returns to a satisfactory level, which usually takes 2 to 4 hours following each treatment session. Spirometry, breath sounds, and vital signs such as heart rate, blood pressure, temperature, respiratory rate, and pulse oximetry are checked and stabilized before discharge. The patient is discharged from the recovery room when the post-bronchodilator FEV1 after the bronchial thermoplasty procedure is greater than 80% of the pre-procedure value and the patient is feeling well. The patient is reminded to use the prednisone or equivalent oral corticosteroids for 1 day following each bronchial thermoplasty procedure. Patient is called 1 day, 2 days, and 7 days following the procedure to assess post-procedure status. Office visits are scheduled at 2 to 3 weeks following bronchial thermoplasty to assess pulmonary function and patient stability for the next procedure and to schedule subsequent bronchial thermoplasty procedures as needed. Follow-up visits for long-term monitoring of improvement of asthma status are scheduled as needed.
After watching this video, you should have a good understanding of how to perform bronchial thermoplasty. The experience of the bronchoscopist, a detailed procedural plan, effective patient management during the procedure, and appropriate post-procedure follow-up are all necessary components to achieve the best possible outcomes.
When performing this technique, it is important to remember that proper patient selection ensures safety. Bronchial thermoplasty is indicated for severe asthma patients who remain symptomatic despite medications, but whose disease status is stable enough to safely undergo bronchoscopy as per hospital guidelines.